Hi, my name is Hope Fox, and today I will be presenting acute bronchitis for Nursing 621. Acute bronchitis is an infection of the tracheobronchial tree that causes inflammation of the large airway within the lung, accompanied by a cough. This can last 1 to 3 weeks. It is reversible and generally self-limiting, so it requires no treatment. Typically, acute bronchitis occurs during the winter months. Other predisposing factors would include cold air, damp climates, smoking, as well as polluted air. The incidence and prevalence of acute bronchitis is it affects all ages, men and women, and children. It is commonly seen in children, and in about 5% of adults, it is seen annually. There is no significant morbidity or mortality related to this disease, and it has a very good prognosis. The data on the cost of the illness, it is a reason for about 10 million outpatient office visits annually, $1.9 billion spent annually. It's the top 10 illness seen in outpatient settings, and is a very common cause for loss of work. The pathophysiology of acute bronchitis is characterized by an infection of the tracheobronchial tree. This infection causes hyperemic and edematous mucous membranes, which results in increased bronchial secretions. It can also cause destruction of the respiratory epithelial lining and denudation of the basement membrane. It also decreases mucociliary function. These changes will resolve after the infection clears. Acute bronchitis is commonly seen after an upper respiratory tract infection that has been caused by a virus or a bacteria. As you can see on this slide, 90% of the causes of acute bronchitis are viral, and only 10% are bacterial. So this will indicate why it is not commonly needed to treat this with an antibiotic. And as you see on there, some very common ones are influenza A and B, parainfluenza, the rhinovirus, the coronavirus. So those are very common viruses we see during the winter months. The chief complaint and patient presentation often includes a persistent cough that's dry or productive, and this is often the main reason they seek medical attention is because of this cough. It's very disruptive in their day-to-day life. They will have malaise, oftentimes wheezing, and dyspnea as well. The hallmark sign of acute bronchitis is their cough. So this is where it's important to get a good ROS with your patient when you're assessing them. They will start with initial dry, non-productive cough that could later turn into a mucoid cough. Their cough is generally over 5 days and can last up to 7 to 10 days. Some of the ROS findings that are positive, they have phlegm, hoarseness, wheezing, malaise, chills, back and muscle pain, headache, and a low-grade fever that's rarely above 102.2. The negative ROS findings would be no hemoptysis, no dyspnea, no postnasal drip, no cyanosis, no tachypnea, and no tachycardia. Upon physical exam, some of the positive findings you may see are bilateral crackles, rhonchi, wheezing, a low-grade fever, and tachypnea. Your negative findings would include a no postnasal drip, no rales, and no fever above 102.2. The patient's past medical history, social history, family medical history, and post-surgical history, often you will see that they are a smoker, they've been exposed to chemicals, they've been around air pollution, they've been in contact with others who have upper respiratory tract infections, or they themselves have had a recent upper respiratory tract infection. Some other differential diagnoses would be sinusitis, allergic rhinitis, pneumonia, common cold, influenza, heart failure, asthma, COPD, and GERD. There are no testing for this diagnosis. It's based on your assessment and the review of symptoms. So to assess for the risk factors, the signs and symptoms, the fact that they have no postnasal drip and no rales. If it's a complicated case, you can do a CBC with diff, an influenza titer, or a viral titer to rule out that they do not have these viruses. Testing that is not recommended is a chest x-ray. It shows no active disease. It will only indicate if pneumonia is expected. There's no need for a sputum culture. Most causes are viral, and a sputum culture normally will grow normal nasopharyngeal flora. There's no need for check the white blood cell count, as is normal or just a slight elevation. The treatment of acute bronchitis is based on treating symptoms. Antibiotics are not needed. To treat the symptoms, we encourage rest, for them to stop smoking, to use a vaporizer, to ensure adequate hydration. This will prevent dehydration and also decrease the viscosity of their secretions. They can use antitussives to help treat the cough and mild analgesics to help with their fever and the relief of their musculoskeletal pain. The length of the illness can last up to 2 weeks, but the cough can persist for up to 8 weeks. So it's important to let your patients know what to expect, that this cough can linger for a while. Patient education would include avoid smoking, no antibiotics are needed, cough may last up to several weeks, and to ensure that they get their vaccines, such as their pneumonia and influenza vaccine, to help them prevent this from happening in the future. Patient education should also include what they need to do if their symptoms get worse and they need to come back and see the doctor or go to the ER. This would include a fever of 102.2, chills, chest or shoulder pain, shortness of breath, cough worsening after a week, a change in their sputum, such as hemoptysis, a green color, or a foul-smelling sputum, a fever that lasts more than 3 days, and a new onset of wheezing. And that's the end of my presentation. I hope that you enjoyed it.